If you're a healthcare professional who treats veins, such as spider veins, varicose veins, venous eczema, or venous ulceration, you're in the right place. Today I'm super excited to be joined by Ronald Bush from Florida. Ron is board certified in vascular surgery and has published extensively on many areas of venous disease. He also has board certifications in thoracic and general surgery, having completed residencies at Walter Reed Army Medical Center and Indiana University. He speaks at major vein conferences throughout the world, and I've been influenced in my practice by his presentations and publications. We're going to talk about a new approach to venous disease called dermatophlebology. The thing I also wanted to talk to you about was the emerging field of dermatophlebology. You've also sent me a presentation, which I'm going to show now, and then I'm going to come back to you
to talk about dermatophlebology, what it really means. And this is a term that I coined at a conference about a year ago that explains the pathophysiology of the venous circuit in the dermis when you have cutaneous venous hypertension. Now, cutaneous venous hypertension, all that means is that there is high pressure from the venous system that's transmitted into the dermis through the ascending branch from the reticular vein that's subdermal. And you can look at the diagram here. It kind of explains what we're talking about. So it's numbered and it's pretty self-explanatory. So the ascending branch is always the gateway for pressure transmission. All these little vessels in the dermis have valves. If one valve's bad, then you're going to get pathology someplace. Now, changes may occur in the squamous epithelium, such as spongiosis, which we'll talk about later, the papillary or reticular dermis. By understanding the various responses to cutaneous venous hypertension, it's easier to diagnose and treat the cutaneous manifestations of venous disease. All CEAP classes contain some manifestations of quite clear that if you don't have changes in your dermis, you don't have symptomatic venous disease. There is a polygonal drainage system that we're showing you here. It's very characteristic. This is from the work of Manishi. The pattern of venous drainage is not set in a straight line. It's actually may or may not communicate. And most of these polygonal drainage systems in the lower leg are triangular in shape. Probably seen this in your patients, especially in the lateral reticular system. Now, dermal changes that occur. Edema. So edema is very characteristic in the dermis, and it can occur with an underlying varicosity. It can also occur around the spider vein. So edema is the first evidence we have of increased pressure that's transmitted through the venous circulation. Now, of course, we also have hypertrophy of the vessel wall if there are spider veins that are present as well. So C4 categories based on 4A is called pigmentation and venous eczema. Well, this is really pretty inaccurate. Bungiotic edema is present in all patients with venous eczema, may or may not be with stasis dermatitis. So pigmentation is not really related to CEAP class 4, except when you have stasis. When you have venous eczema, you have spongiotic edema with very little dermal involvement. The discoloration of the skin is actually from the squamous epithelium and usually from perforators. So if you have a lot of itching, a lot of pruritic symptoms, you get chronic skin changes. But it's not from pigmentation such as the hemosiderin deposition. So this is edema. This is venous eczema with some edema. You don't see it here. With stasis dermatitis. So it's quite different, yet they're grouped in 4A category, which is really inaccurate and needs to be changed. So telangiectasia, according to the study of dermatophlebology, have distinct classes. Okay. Now there are classes of telangiectasia that are associated with cutaneous venous hypertension. The red telangiectasia are about 150 microns in the subpapillary plexus, which is continuous. Now the blue ones are about 500 to 600 microns in depth. There may or may not be continuity with other polygonal drainage systems. So there's distinct categories of telangiectasia associated with cutaneous venous hypertension. The red ones you see are in the subpapillary plexus. The blue ones are in the dermal plexus. You may have both together or you may have either one alone. Depends on where the valve is damaged and the method of pressure transmission. So angiogenesis. Now this is commonly found in the reticular dermis. It's the same level that the blue telangiectasia occur. It's not associated with venous hypertension, but rather with inflammation. You can see here the wall of the vessel is thin. There are lymphocytes present. You never see lymphocytes unless you have inflammation. Now we do see inflammatory changes with lymphocytes in some vessels overlying varicosities. So what we do is a lot of times we'll do the punch biopsy. We use a 1 millimeter punch to do the phlebectomy, and we'll examine the skin overlying the varicosity, and we find edema in the dermis itself. This may explain why some people have more symptoms than others, such as itching, pain, etc., because they have more inflammatory changes. So this is generalized essential telangiectasia. The vessel wall is hyalinized, does not respond to sclerotherapy. If you do sclerotherapy, you're wasting your time. This has to be treated with a low wavelength laser or IPL. So in conclusion, this is a very brief overview of dermatophlebology. We have a lot more that we can discuss. I wanted to tell you what we're actually investigating now. We're looking at the venous changes that occur in the dermis, which really have never been studied very well. So this dermatophlebology is simply the study of the alteration of the venous circuit in the 2 millimeter thickness of the skin of the lower leg. Transmitted high pressure causes a multitude of findings. By studying the different modalities of treatment, we can actually study and know how to plan our effective treatment. So any other information we can help you with, just contact us by email. It's very, I think, a new developing specialty. Or just kind of a brief overview of the dermatophlebology. I'm also going to attach a paper that we recently published, and also there's a textbook coming out in the next few months.
This is something that a lot of vein specialists don't know, and I think it's because you have routinely performed phlebectomy through punch holes, through punch biopsy, and you've sent those biopsies away for analysis. And that's led to your interest and knowledge about dermatophlebology. Tell us a bit about that.
Well, I think that my interest in dermatophlebology really started when I moved to Florida. And Peggy and I were just going to maybe open a small clinic and do some sclerotherapy, do some things in the office. But then Ted Schiff contacted me. Ted Schiff was the founder and president of all the Water's Edge dermatologies, now they're called Aqua, and there's about 130 clinics. Ted and Dr. Shama, Nick Shama, were classmates. And Nick Shama and I did a lot of the early work on histology of what happened after you do a laser. What does the vein look like? And histology of the venous aneurysms. Excuse me. Ted said, why don't you come here and work? And I said, oh, good idea. So I started doing veins in a dermatology practice. And then I had access to the dermal pathology lab. I have my own Cytotech technologies. He works just for me when I do my specimens, but he works for the lab, but he's the only one that does my specimens, and he's superb. I mean, he gets everything you see from our work is, for the most part, through 1 millimeter punch biopsies. As you mentioned before, I use that many times for doing phlebectomies. How I got started doing with the spider veins is that we would, as you mentioned before, this technique of doing tumescent and then doing the sclerotherapy afterwards. Well, as you see, when the spider veins fan out, the point from where they fan out is a point of their dermal perforator entrance into that complex. And each group associated with one dermal perforator. So we started doing like foam sclerotherapy or using different solutions to see which would give us the best result of sclerotherapy. And we would do a punch biopsy of the dermal perforator. Everybody got a punch biopsy of the dermal perforator. And then as we gained more knowledge, we also did punch biopsies of the larger intradermal varices. So we could actually see what these look like, what they look like after they were treated. And so that kind of got it really interested in what was going on. And so when I read Manishi's report on polygonal drainage, everything kind of fell into place about, gee, this is what all this stuff's about. So we were able to reconstruct, and I'll tell you in a minute how we did that. But for the most part, we're doing, let's say, class 1, CEAP 1 spider CEAP1 category, spider veins. It's common knowledge that spider veins are theoretically cosmetic. But what dermatophlebology has taught us when we do our biopsies is that maybe that's not always so, because we can see in the specimens many spider veins have associated reticular edema. So that's a class 1 with edema. Does that make it a class 3? So what I'm getting at, the CEAP categories are all wrong. Study of the dermis has proven that it's much more complex than just 1, 2, 3, 4, 5, 6. Spider veins can also be aneurysmal. Okay, what's an aneurysmal dilatation of the spider vein? Well, it's 3 times the size wall thickness of a normal spider vein. So all spider veins have thick walls. Okay, now other thing in dermatophlebology that you can see is that, wait a minute, not all spider veins do have thick walls. There are some that have thin walls, called generalized essential telangiectasia. They do not respond to sclerotherapy. But we know from our studies, after we've actually done specimen biopsies to confirm it's GET, we have a patient that we've treated, not clearing up. I suspect it's GET. I will do a biopsy. The reason is that I can tell the patient, look, you're not going to clear up with sclerotherapy. You may clear up with IPL. You may clear up with laser in a certain wavelength, okay, usually a V-beam, which is about 590, but you're not going to clear up with sclerotherapy. It's just not worth doing. And so they have to, you tell them that so they can at least know that they have the option of going on having phototherapy. It's going to be more expensive for them, probably. So red spider veins, everybody goes, well, we have red and we blue. Why do we have red and blue spider veins? Okay. Well, we have red spider veins because they're in the subpapillary plexus. That's where they reside 100% of the time, 150 microns below the skin level. Why do we have, and they have less, desaturated blood. Why do we have blue spider veins? Well, they're in the mid-dermal, classified mid-dermal area, but they're really not mid-dermal. So the dermatophlebologist and I did about probably 30, we took 30 slides of a lot of the spider veins we've done. And we measured the actual depth of a spider vein, the blue spider veins. Most of them are at 500 microns, 500 to 600 microns below the skin sector, consistently. Very surprising, but that's the case. That's where they are. Now, you can have deeper ones. Here's the trick. You're not going to see them. You only see the ones that are in the upper dermis. You very rarely ever see the ones in the lower dermis, unless they're really dilated. Now, when you have aneurysmal dilatation, you have many spider veins that are dilated per microscopic field. Whereas when you have an aneurysm, when you have a regular spider vein, it's one. So, these are the things that we've come across in dermatophlebology that we've learned about and correlated with the ultrasound findings. That's the CEAP1 alone. Now, CEAP2 category, okay, we're looking at that now, and that's been reported that some patients with dysvaricosities will have dermal edema. Okay, that's been reported by, I think, Etiology did that and had a paper on that. And that's true. We see that one time. And probably about 20-25% of the patients will have dermal edema, which when you scan the varicosity, you can see a really thick dermis above it. Now, if you've ever really thought about this, why aren't there spider veins above the varicosity? Very rarely ever see that or in a lot of locations. So is a dermal edema secondary to venous hypertension, okay? Or is it secondary to lymphatic obstruction in these patients? And that's what we're trying to determine now. It's really difficult to see lymphatic channels. We don't have electron microscopy. We just have the standard examination, microscopic examination. So that's what I'm looking at now, categorizing how many patients with actual, what we would consider CEAP2, have actual edema. And why that's important was that puts them in a different category, right? They're no longer class 2. That ups the venous severity score by 3 right there. Just having edema, because that edema doesn't go away. Okay, it stays there. Now, is it lymphatic or venous? I think it's lymphatic because when we do the biopsies, I've seen some channels, but we don't see thickened blood vessels. We don't see increased blood vessels in the papillary dermis. So by just inference, I think it's probably lymphatic, isolated lymphatic drainage disturbance just around the varicosity. Then we have class 3, which is a standard edema. Okay, well, now we've seen there's edema in class 1, there's edema in class 2. So, we have to be more specific. saying this is dermal, this is edema in the subdermal tissue, okay? Because class 3 really means in the subdermal tissue, because most people with edema don't have edema in the dermis just from venous insufficiency, unless they have other pathology, which leads us now to CEAP4. So CEAP4, by the revised standards, CEAP4A is described as eczema, okay, and pigmentation. It's grossly inaccurate. Eczema has nothing to do with pigmentation, okay? When you see pigmentation eczema, that's just from skin excoriation. If you do an eczema biopsy, okay, a biopsy of a patient with eczema, what you see is a different type of edema. A true eczema venous patient will have what's called spongiosis. They'll have actually edema in the squamous epithelium, which you don't see unless you have eczema. And eczema, that's a classic finding, any kind of eczema. Eczema from, from allergic reactions, from poison ivy, whatever. They all have spongiosis in the squamous epithelium. And we've actually seen patients with eczema have spongiosis in the squamous epithelium. Have these water, they're actually like little cysts of water, little cavities of water in between the keratinocytes. I mean, it's a very interesting finding. How that occurs, not really sure. It's some immune regulated response, but pigmentation, they don't have pigmentation in the tissue, in the reticular dermis, okay? You do have pigmentation with stasis dermatitis, but you shouldn't class that as the same category as eczema. They're different. So maybe there should be a class 4A that says only eczema. Class 4B should then maybe be reserved for stasis dermatitis, which is pigmentation, secondary to red cell extravasation and hemocentrin deposition. So I think dermatophlebology is just evolving, and we'll learn more and more. And I think another important part, if you don't have skin findings, you don't have symptomatic venous disease, period. And so even people with spider veins may have symptomatic venous disease, especially if they're aneurysmal. And if they're aneurysmal, especially down by the foot, they bleed. They're the great source for bleeding. If they have edema, I think these patients, I've seen these patients have more problems with pruritus and kind of skin sensation changes. And that may be the patients who develop that, the ones that have the edema. So that's kind of how we got into that. And we're still studying this and trying to go and to learn more. Like I said, now we're trying to find out how many patients actually develop dermal edema varicosities. Because I think it's important, because the insurance companies get more and more regulated on who they're going to treat. Well, now you have somebody with dermal edema with varicosities. It's not just simple varicosities, it's something else. Do they have more symptoms? That's what we're trying to see. Do they have more symptoms of heaviness and fatigue? It's a possibility. So we're still in the early phases of this.
Well, it's great to hear, and great to hear how you're taking this forward, Ron. I'm going to wrap up now by signposting people to your website where they can find out more about dermatophlebology,